Welcome back. Personality today. Do you know some people who are destructive, toxic, unchanging, parasitic, selfish, volatile? People whose presence ruins cooperative efforts. People who other people avoid. These individuals may have personality disorders. Do you know a lot of people who meet this description? Are most of the people you know destructive, toxic, unchanging, parasitic, selfish, volatile? People whose presence ruins cooperative effort. Then you may have a personality disorder. Personality here is just defined as an individual's typical way of behaving and thinking, and we tend to assess it in terms of traits. A personality disorder is a persistent pattern of emotion, cognitions, and behavior that results in enduring emotional distress for the individual or others. And this we assess in terms of dysfunction, or how you fail to adapt to your environment. This lecture will discuss how the DSM has changed and not changed over the years, how the Psychodynamic Diagnostic Manual, which you were introduced to in the Lecture 3 reading, tackles what it calls personality syndromes. We'll look at which categories of disorder or syndrome are currently recognized by the DSM-5 and Psychodiagnostic Manual 2. And in order to showcase a variety of lenses, we'll look at borderline personality disorder through different DSM versions, the Big Five, the Milan multi-axial and spectral approach, and a couple of others. Borderline personality disorder is chosen because it tends to be the fail point of a lot of psychological and psychiatric models of abnormality or pathology. Many theories seem to do fine until they meet borderline personality disorder. None of the hedgehogs do a very convincing job of explaining it, and the foxes tend to be rather pessimistic about understanding it as well. Brief points for and against the use of personality disorder concepts. Here is my attempt to motivate you to believe, at least for the course of this lecture, that personality disorders are important. First, disordered individuals are extreme on some trait on which you also have a score and variation. If considering disorders, we're also considering extremes of behaviors of which we may be capable. It is therefore a kind of ethics or secular look at values. What ways of being in the world are wrong, adaptively and normatively? What of the ways we appear to agree are not the ways to consistently be? Second, the more one studies personality disorders, particularly the DSM Cluster B personality disorders, narcissistic, antisocial, histrionic, and borderline, the more one tends to become convinced that their impact is the single greatest problem facing humanity. Humans are built with vulnerabilities, and some humans with extreme personalities are built with special exploits that take advantage of those vulnerabilities. Personality disorders appear to pose a threat in positive relation to how altruistic, caring, and enlightened the environment they operate in is. The nicer everyone is to the individual who's a psychopath, a narcissist, histrionic, or borderline, the more goodwill they are shown and trust they are given, the more they take, harm, and violate. The less on guard for cheaters that the social world is, the more advantageous it is for those unconcerned with the rights, value, or well-being of others to cheat. These individuals abuse our friends and our relatives, infiltrate and corrupt our well-meaning social movements and honored institutions, and make us question reality, make us question whether a kind and open society is even possible. Since every group of individuals likely has a subset of toxic cluster B personality disordered individuals within it, harmful personality disorders are the seed of self-destruction that comes pre-planted in every social undertaking. And as with every other psychological disorder, it is the thankless task of the rest of us to figure out how to build a family, a workplace, a social network, a social movement, a social organization, or society that tolerates, accommodates, and survives the existence of extreme personalities. Maybe you think you can prevent the B people from getting into your club, movement, organization, or social circle. Maybe. But whatever virtue you seek can likely be dishonestly signaled by someone as expert in self-presentation as an individual with narcissism, as skilled in charm and deception as a psychopath, as skilled in seduction as the borderline individual, or as dramatic and performative as the histrionic person. In fact, they are experts at making themselves into exactly what you are looking for, at least for the time being. Too long didn't listen? The study of personality disorders shows us what we value as individuals evaluating the disorders and as members of the society that has delineated these disorders, and it helps us identify the people who are disproportionately a threat to good in the world, if only by virtue of having to prioritize themselves over anything we might call values. Maybe that's overselling it, but I don't want anyone to go into this thinking that in describing some disorders, we are just describing disorders. Indeed, we're doing far more than that. We're probably ruining people's lives and understanding of themselves. Diagnoses of personality disorders are, of course, fictions. Nobody is a biological or inevitable or categorical narcissist, if only because humans could change their behaviors. Someone with dementia may not be able to act as though they don't have it, but someone with a personality disorder could. The classification is a useful fiction that describes certain behaviors and self-described ways of being. Personality disorder diagnoses are labels, and label theory states that diagnostic labels, like all labels, serve as stereotypes, function as pejorative labels, come to be viewed as simplistic answers to all of the patient's behavioral problems, and once administered, or declared, or affixed, the label sticks with the person forever from that point. Contrary to what you may expect or believe, people do get better from personality disorders, though the language used is usually that individuals mature out of or grow out of their disordered ways of being. Label theory doesn't say we should get rid of labels. It just reminds us that they can and do work against our purpose of trying to help people understand themselves and adapt better. Since label theory often reads like common sense, I chose something more dramatic for my second point here. In arguing against the use of psychiatric labels, Thomas Szasz used the metaphor of a gun, specifically a gun in the scene of an action movie. When the hero and villain are fighting, there's one gun, it slides across the floor, and now it's a race to see who can get control of the gun, because we know that the first person who can pick up and use the gun will win the fight. The other methods of combat go out the window, now it's a race for the gun. Similarly, in personal relationships, in institutional relationships, in political discourse, if you can be the first to wield the all-powerful and all-framing psychiatric label, then you win. Very rarely after such a label is wielded do you have a chance at return fire. This brings to mind our motives and the potential consequences of what we're doing when we are fixing a personality disorder label. Are we simply attempting to contain or defeat a difficult person who presents a problem to us? Or are we trying to help, not realizing that this help could be fatal to the individual, as someone who's more than their diagnosis? Are we motivated? Let's get into it. History first. The DSM was cobbled together from at least three major sources. First, and most importantly, there was the distinction, or categorization, made by Emil Kraepelin. The difference between manic depression, which we now call bipolar, and dementia praecox, which we now call schizophrenia. This was not just an observation of symptom difference, but also of likelihood of recovery and differences in terms of how these individuals responded to pharmacological experimentation. Second, and dominant in terms of popularity when the first and second Diagnostic and Statistical Manual editions were being written, was psychodynamic theory and language, especially regarding neuroses or nerves and anxiety. Arguably, without Freudian psychoanalysis, psychiatry would not have been big enough of a profession to even require a diagnostic manual. With the work of these two, who were both born in the same year, 1856, we have the medical asylum, psychosis and mania, and private practice couch, anxiety and depression, adequately covered. But arguably, most of what we see represented in the personality disorders section would not be here at all without the third source of influence, the Army Medical 203, which provided codes to explain problems seen in military personnel in and after World War II. If something made someone less fit for military duty, then it needed a code. When this was turned into the DSM-1 in 1952, disorders of personality included being passive-aggressive, Code 321.1, or wetting the bed, 321.3. So things like addictions, trouble learning, sleepwalking, were all personality disorders in the model that got pasted over from the Army and Surgeon General. Over the next 16 years, in a context that is largely psychodynamic in orientation, the personality disorders get winnowed down to categories or challenges we would better recognize as being personological or characterological. Then, over the next 12 years, the DSM makes more changes, including introducing 2 cluster B disorders, narcissistic and borderline. And the DSM-3 introduced axes and placed personality disorders on a separate axis, along with developmental disorders. This was meant to be in recognition that personality and developmental concerns can be separate and alongside other major disorders. But it was taken despite this warning. This does not imply that these Axis 2 disorders are not mental disorders, to mean that they were lesser or non-disorders by insurance companies and psychiatrists alike, with insurance companies not covering meds for Axis 2 disorders and psychiatrists often deferring diagnosis, i.e. writing Axis 2 deferred rather than actually doing the work of documenting a personality disorder diagnosis. 14 years after that, we have only minor surface-level changes, like the O in obsessive-compulsive personality disorder coming back. Because if you look closely, it was obsessive-compulsive in DSM-2, just compulsive in DSM-3, and then it was back to obsessive-compulsive in DSM-4. You'll also notice that passive-aggressive isn't on the DSM-4 list, but it's not that it was completely absent. It was moved to the appendix. So here's the history of passive-aggressive personality disorder. Here it is in 1952. Are you passive-dependent, characterized by helplessness, indecisiveness, and a tendency to cling to others as a dependent child to a supporting parent? The passive-aggressive type of passive-aggressive personality disorder? Do you react with pouting, stubbornness, procrastination, inefficiency, or passive obstructionism? In other words, are you not a good soldier? Are you sending out signals that suggest you'll become insubordinate? Or are you the aggressive subtype? Do you respond with irritability, tantrums, and destructive behavior? There it was, in the main body of the DSM-1 in 1952. Then in the DSM-2, we moved it to the appendix, because that's where things go, if we think they may be useful, but we can't quite justify having them as a category. And in 1980, the DSM-3 brought it back into the main body. Then the DSM-4 put it back in the appendix, which is why it's not on that list from the previous slide. And we don't see it on the DSM-5 list either, or do we? What's new in the DSM-5 is the bottom section here. Code 310.1 allows for personality change due to something like a brain injury. As psychology students, you're all familiar with the case of Phineas Gage, a man who had a tamping iron shoot through his prefrontal cortex, destroying some of it, and then had a change in personality. Well, we now have a personality disorder code with which we could diagnose the Phineas Gages. And this new category of other specified is like a cheat code that allows us to play old characters. Do you want to diagnose someone with an historical personality disorder that isn't currently listed in the DSM-5? You would just assign this code, this diagnosis, and then specify which legacy diagnosis you mean. Would you like to diagnose someone with passive-aggressive personality disorder? The DSM-5 uses it as its example of a disorder that you could bring back with this code. The other specified category also allows us to diagnose mixed personality features. So other specified with mixed personality features. So maybe you have features of antisocial, borderline, and paranoid. If you otherwise meet threshold, I'll say other specified with mixed personality features and then specify which features those are. But our tour of the DSM-5 is not complete because the DSM-5 had made a whole bunch of promises that it was going to revamp, make big changes in how personality disorder diagnosis worked. Specifically, they wanted to adopt a trait-based spectral approach that allowed for more nuance in interpretation and solved the strange threshold problem, whereby you could meet 4 out of 7 criteria and therefore be diagnosable. But if something suddenly changes, say for example you have paranoid personality disorder and then suddenly you start trusting your spouse, that change could make you fall out of the category of paranoid personality. But there were other criteria and adaptive challenges that don't suddenly go away because you trust your spouse. The categorical model with the existence of its threshold doesn't seem like a good way to conceptualize things. So the DSM-5 committee attempted to make a more nuanced, spectral approach, but it ended up not being ready for prime time, so they put it in an appendix and said it's not for clinical use, but consider it, maybe do some research on it, and we can circle back to it when it comes time to do revisions. So in that appendix, we see this alternative model. What do you need to get a personality disorder diagnosis? Impairment in self or interpersonal functioning, one or more specifically identifiable personality traits that appear to be the problem, pervasiveness of the problem across social situations, stability of the expressed problematic trait, and E through G are about ruling out alternative explanations and diagnoses. So is this just up to clinical judgment? Is it moderate or greater impairment according to the psychiatrist or psychologist? Kind of, but it's specified in that you need to check at least two of these categories off: identity, self-direction, empathy, and intimacy. If you have problems with at least two of these, then you have moderate impairment in functioning. Okay, that's criterion A. For B, you don't get to just make up a personality trait on which they're too extreme. You have a list, presented here for your squinting pleasure. This list is divided into 5 broad domains, which don't map perfectly onto the Big Five or 5-factor model. They're actually a hybrid of research on the Big Five and research on typologies from the MMPI-2, the Minnesota Multiphasic Personality Inventory, current version. But you should be able to recognize the Big Five here, at least with negative affectivity, which corresponds to neuroticism, detachment, which would just be very, very low extroversion, antagonism, which is the flip side of agreeableness, disinhibition, which is the flip side of conscientiousness, and psychoticism, which gets most of its research justification from the MMPI-2. So criterion B gives us 25 different traits on which we could be abnormal. In addition to the proposed diagnostic criteria here, the alternative model also retained 6 personality disorders specifically, so you don't have to reassemble these from their constituent parts in order to diagnose them. You can just say borderline, obsessive-compulsive personality, avoidant, schizotypal, antisocial, or narcissistic. But if the personality disorder you are diagnosing is not one of these 6, then you're going to specify the trait domain. If the client seems to have a problem with the entire domain, so someone with schizoid personality disorder could likely be seen as having a problem with the detachment domain. Or if the individual doesn't have a problem with the whole domain, just specify the facets or subdomain traits on which the individual is experiencing pathology. Changing gears now, let's move from our walkthrough of the DSM to a psychodynamic perspective on abnormal personality. Some review from Intro Psych in case you didn't take it or in case you didn't take it with me. We already have a key Freudian idea. The way that we learned to resolve anxiety states when we were younger is the way that we tend to resolve them now, especially if back in our past we made a lot of use of them. So with Freud we have the challenge of anxiety. We all individually are dealing with the fact that the world makes us anxious. The world presents us with problems that are bigger than ourselves, realizations of our tininess, our insignificance. We exist in the world with needs. If we needed nothing from anyone, if we needed nothing from the world, no food, no nourishment, no love, we wouldn't really have anxiety. But we have needs, and therefore we have anxiety. We have conflicting needs. What Freud called our id needs sexual gratification, to eat lots of delicious food, to drink when they can't get sexual gratification, which is something that even fruit flies will do. If you deprive a fruit fly of sex, it will drink more alcohol than if it had had sex. And unlike some therapeutic paradigms, the psychodynamic model isn't just worried about your needs that currently are not met or would be difficult for you to meet according to the strictures of society. So maybe you want a certain kind of sex that the world isn't ready for or something like that. Also needs that were not met or maybe were overmet in your past. So maybe you were spoiled or deprived. Anxiety when you were less mature, when you were less capable of meeting the challenges of the world, and when you were little you used certain defense mechanisms. When you were very little you cry. As an adult that doesn't look good. It's the defense mechanism of regression. Maybe when you were small and powerless you learned to ignore the things that caused you anxiety because you maybe had no other option. That doesn't look good as an adult. That's denial. The pattern here is the defense mechanisms that we employ in order to protect ourselves from anxiety when we're little
don't tend to work very well when we're adults, when more is expected of us. And the more we have to use these immature defense mechanisms as a child, the more ingrained they would be in our adult behavior. And for Freud, this did indeed go all the way back to our infancy. So, take a step back. What are we talking about with defense mechanisms? General approaches to satisfying your ego's need to feel like it's doing a good job. Your unconscious protects your ego from some of the things that it cannot control, that it cannot address. Your unconscious may learn certain tricks, and it may over-rely on specific tricks. This is where the topic of personality comes in. If you have a specific defense mechanism that you've learned to use, maybe it's denial or regression, then that over-reliance on one mechanism can be described as your character, your typical way of dealing with problems. It can be described as your personality. In psychodynamic parlance, some defense mechanisms are characteristically more mature than others. Here's a listing of mature to pathological. One mature way of dealing with your anxiety would be self-observation. So I'm a little anxious because I'm having impure thoughts. I'm having thoughts that I'm not supposed to have. Maybe I can start monitoring them, understand why I'm having these thoughts. Maybe you write them down. Self-observation. If something bothers you, well, then it might only gain strength if you keep it in the shadows. So bring it out to light and see what this thing that's making you anxious is. That would be a mature way to deal with anxiety. Moving from mature to pathological now. For the psychodynamicists, we're now at the level of neuroticism. So the joke is we're all a little bit neurotic. That is, our way of adapting to the world is not ideal. With neurotic levels of functioning, you are not thriving, but you are at least within the realm of reality. You're probably adapting well enough if you have a neurotic level of personality organization. So an example of a defense mechanism that is typically at the neurotic level of personality organization is displacement. My boss yells at me and this bothers me, but I don't give it back to my boss because that wouldn't be prudent. The boss can make decisions about me. Maybe I go home and I'm extra cranky towards my wife. She doesn't deserve it, but she is at least somebody that I can displace onto, and maybe she will understand why I'm engaging in displacement. So we can have a perfectly functional neurotic level of organization. She understands why I'm being rude. She doesn't take it personally, but this also brings up one of the issues with personality, especially neurotic level of organization of personality. It's a lot of work for other people. We all know individuals, maybe members of our family, who are just a lot of work to be around. These are generally people with neurotic levels of personality functioning. Next, we're again moving from healthy, mature types of defense mechanisms to more pathological ones. Next, devaluation. The classic Aesop's fable story is a fox and he wants some grapes, and he jumps and jumps and he realizes he can't reach where the grapes are. So he looks at the grapes and he says, well, I'm glad I can't reach those grapes because they're sour anyway. It protects the fox's ego from experiencing failure. Well, it's actually a good thing that I failed. What makes it rather pathological level of organization, actually this level is what the psychodynamicists call the borderline level of organization. In other words, your personality is kind of on the cusp between splitting with reality, which is a psychotic level of organization, and sticking with reality, however imperfectly. So reality doesn't conform to what your ego needs. The fox's ego needs for those grapes to be sour. Otherwise, the fox is a failure, and the fox can't deal with failure. The fox says, well, those grapes are terrible. So we start to see that this type of defense mechanism is starting to deny reality. This is what's going to make it functionally a challenge for the individual who is adopting this defense mechanism. It's not a good idea to start separating off from reality and denying things that exist just so that you can feel better. Keep in mind, this is not intentional. This is your unconscious, for the most part, in order to protect your ego from falling apart. So let's move all the way to pathological functioning. What in psychodynamic parlance is psychotic level of organization. You have defense mechanisms like apathetic withdrawal. Maybe the fox learns not to care. I don't care about those grapes. I don't care about anything else. You do care. You want to be loved. You want food, companionship, respect, belonging, achievement. You want all these things. But if you have characteristically not been successful at doing them, maybe you stop trying altogether. These are immature pathological defense mechanisms. Let's do one more round from healthy to pathological. So altruism. Something makes you feel morally bad. Your way of dealing with this would be to do good. You give to charity, you give your time to somebody, you help someone else. So this is altruism. This helps you. It helps your ego to feel better. It's a healthy defense mechanism. Moving to neurotic now. So something that is at least acknowledging reality, maybe not doing the best, most effective job at it. Reaction formation. Let's say you have the wrong feelings. There's something that you believe that you're not supposed to talk about. Rather than deal with this mix-up between between what you believe is true from a societal standpoint versus what you think is true in terms of you individually. You say, well, you know what? I am going to fight for what society says is right, and I'm going to be the extra vociferous of fighting for what society apparently believes is right. This is to distract you from the reality that deep down you actually believe the opposite of what you are vocally fighting for when people can hear you. A borderline level defense mechanism. Projection. I have a thought in my head, and it's not necessarily a good thought. It must be a thought that's in your head. I must be reading your mind. So it's not me who thinks this thought, it's you who thinks this thought. It's not me that doesn't like you, it's that you don't like me, and that's why I don't like you. You didn't like me first. This is projection, and you can imagine how it would be exhausting to talk to someone who is projecting, who is putting their own securities, their own beliefs, their own anxieties, and saying that they are yours, and these are problems that exist in you. Here you're kind of teetering on complete misunderstanding of reality, which is not adaptive, psychotic level of functioning, and something that may potentially be useful because at the very least you have the right theme of what needs to be addressed. And finally, an immature or pathological type of defense mechanism, denial. Does it bother you that you might have a drinking problem? Well then, what if you could just say that you don't have a drinking problem? That might make it go away. Well, guess what? It doesn't. This is why it is a psychotic level defense mechanism. So the classic defense mechanisms are displacement, recalling that the ego's task is to satisfy as much as possible the id and the superego. Displacement says, well, you're not allowed to punch your boss or to walk out of a test that's stressing you out, but you are allowed to break your pencil or to be mean to your partner or children. The evil little id that needs to feel powerful can feel powerful while acknowledging some of the strictures from the superego. Regression. Maybe you know somebody who uses this one. Those who have been rewarded for feigning helplessness, for saying that they need to be cared for and protected, may do this characteristically. And this is one of the examples that it's easy to see is an immature, or what we also call primal type of defense mechanism, because you are actually acting like a younger child. What's one thing we can do when we have a parent around, when we are tiny and the world overwhelms us? We can ask for help. We can make ourselves as helpless as possible, as pathetic as possible, as cute as possible, in the hopes that those around us will expect less from us or maybe help to solve our problem. Projection is when we impute qualities we do not like or are not allowed to like about ourselves onto other people. Here's a little cartoon. I know that you're thinking terrible things about me. Well, screw you and your judgment. And the guy on the other end of the conversation says, well, I was just thinking about pie. In fact, he's perfectly happy. So here's denial again. Denial is saying that the anxiety-provoking bits of reality do not exist. No, that they don't. They're fine. Okay, so how is denial different from repression? Well, let's just put them next to each other and you can probably see for yourself. Denial is saying that the anxiety-provoking bits of reality don't exist, whereas repression is not knowing that the anxiety-provoking bits of reality exist. With denial, you can have knowledge of the thing that you're denying. In fact, you kind of need to. There's a third defense mechanism here that could kind of be chained onto repression and denial, which is suppression. So suppression is a healthy, mature defense mechanism. Let's say somebody says something that bothers you or some sort of conflict comes up, but you can't deal with it right now. And how many people have said this? I don't have time to deal with this right now. That is the defense mechanism of suppression. So I can't deal with it right now. This is an anxiety-provoking thing, but I'm going to put a pin in it. I'm going to come back later and then deal with it. So it's one way of managing anxiety. I'm going to unpack this later when I can process it with more attention. That's healthy. And then you have denial, which is a psychotic level of organization, right? You're denying reality exists. And then, of course, you have repression, which is also your unconscious protecting you from knowledge of reality. But they can be put in order from suppression, denial, and repression in terms of knowledge. With suppression, you know the problem is there. That's why you put a pin in it and say, okay, I'm going to solve it later. You're suppressing your urge to solve it now for the time being. With denial, you're kind of in between worlds. You are acting as if the thing doesn't exist, but clearly, since you can deny it, you know that it exists. Okay, great. So you're kind of in between spaces there in terms of knowledge. So you can put them in a row from more mature knowledge about something to less mature knowledge about something. Suppression, denial, and repression. Reaction formation, behaving in the opposite manner as to how you would unconsciously like to behave. A therapist who thinks that you have some sort of resistance because your beliefs are a reaction formation against what you actually want or who you actually think you are. We'll note the strength of your belief and then infer that the strength of your belief is actually an index of how much you hold deep within yourself the opposite of that vitriolic belief to be true. So why does this man in the picture care so much about homosexuality? The Freudian therapist might have something to say along the lines of, the louder he shouts, the more I think he's bi-curious. A relevant Shakespearean meme here is, methinks she doth protest too much. Rationalization. In any healthy, functioning human brain with an imagination, you can probably come up with a reason why maybe any old behavior you engaged in could have potentially been a good idea. Your brain is really good at this. This has been noted by cognitive scientists. We're good at coming up with reasons, even for very stupid behaviors, and we're good at coming up with explanations other than the one that is the truth, if the truth makes us look bad. An example of rationalization, Dave Eichelman in the Zimbardo prison study, his argument was that he was so terrible to the prisoners in the experiment because Zimbardo wasn't stopping him from being so terrible to the prisoners in the experiment. One test that this does not pass is the temporal precedence test. How could the lack of response to something be responsible for the thing that it was supposed to respond to? One of the reasons why smarter people tend to have a more difficult time learning actual new things is that they're very good at rationalizing why they don't know those things, or why it's a good thing not to know them. I see some really terrible rationalization on the parts of students who seem willing to entertain pretty much every idea except the idea that maybe they didn't know the material as well as they thought. And here's one of my favorites, intellectualization, making an issue more abstract or removed than it really is. The Velociraptor, I failed, but what is failure? Why deal with failure when you can problematize the idea of failure? An example of intellectualization that you could engage in now that you have a few defense mechanisms in your arsenal might be to catch yourself engaging in a stupid behavior or a stupid decision, and then you could find out the defense mechanism that describes it, and then you can make a judgment as to whether the defense mechanism is a good thing or a bad thing, rather than focusing on the actual behavior that you should be admonishing yourself for. And here's a mature or a healthy defense mechanism, sublimation. Artists must suffer for their art. This suffering and conflict gives them the anxiety they need to push into new territory for artistic creation. The worse the suffering, the better the art, because you have more pent-up psychic energy to sublimate. So recall that while we can say that some defense mechanisms are more mature than others, some mechanisms are more immature, more primal than others, it's not just your choice of defense mechanisms that matters, but whether you kind of have a choice in defense mechanisms. If you only go to one defense mechanism every time, then you don't really have very adaptive coping for dealing with life's issues. Another mature defense mechanism is humor, but of course you can't use humor in every situation. So it's a healthy, mature defense mechanism, but if it's the only one that you have, you're going to get yourself into some trouble functioning. It's not just about the defense mechanism itself, but also about being adaptable and having different options to choose from. So it's probably not hard to imagine somebody who relies on regression or intellectualization or projection. Regardless of what makes them or their unconscious choose these specific defense mechanisms, these are, for better or worse, their personality. So, our personality can go wrong by using the more pathological, immature, or neurotic defense mechanisms, rather than the healthy or mature ones. Being inflexible in our use of the defense mechanisms. For example, regression or crying will not get you out of everything, and these patterns or habits tend to get established very early. Here's the Psychodynamic Diagnostic Manual, also called the Psychodiagnostic Manual. You've probably sat through lectures where people make fun of Freud and psychoanalysis for being unfalsifiable and concerned with impractical or theoretically abstruse things. Maybe I was giving those lectures. So why should we give any attention to the Psychodynamic Diagnostic Manual? Well, the DSM-5 and the current editions of the ICD are largely concerned with reliability, and they tend to be stuck with the categories they have, i.e. resistant to change, because they're part of a larger web that would have to change along with them, so there's lots of pressure not to update. And as the name International Classification of Diseases would suggest, the emphasis is on the disorder or disease or illness rather than on the person as a dynamic part of the disorder being experienced.
The DSM-5 is explicitly atheoretical. It makes deliberate attempt to not explain the how, why, and wherefore of disorders. It attempts to be descriptive only. This is what it is. The Psychodiagnostic Manual follows the psychodynamic tradition of not really caring about classification and diagnosis. When it came time to negotiate and vote on the DSM-3, which was published in 1980, the psychodynamic psychiatrists were openly pushing for more ambiguity and room for clinical interpretation, in part because individual cases are so different, and a checklist approach that bins somebody based on just a handful of criteria can misrepresent a case or lead to premature closure or the illusion that you understand more than you do, or an illusion of similarity between cases, or the idea that a person couldn't jump categories and experience a different disorder categorically, even though they're still experiencing the same challenge, just a different manifestation of it. So the Psychodiagnostic Manual contains diagnostic categories, but looks at things dimensionally, not just in the box of diagnosis, but in general. In their own words, the PDM's interested in the full range of human mental functioning. And like the DSM-4, the Psychodiagnostic Manual has axes, one of which is personality, the other's mental functioning, and the third is subjective experience. Schizophrenia would be a disorder of subjective experience. You saw in your Lecture 3 reading the Psychodiagnostic Manual's take on personality disorders. Many of the personality theorists who went on to be cognitivists and identified types of pathological thinking started out as psychoanalysts, so their research slots nicely back into psychodynamic models. The columns of characteristic pathogenic beliefs come from psychodynamic, rational emotive, cognitive, and cognitive behavioral research. What you may notice is that there are more personality syndromes here than we saw in the ICD and DSM, including somatizing personality, sadistic personality. Here are the disorder lists next to each other. Notice that the International Classification of Diseases and the Diagnostic and Statistical Manual are nearly identical. The DSM-5 has schizotypal in its personality disorders section, but it's special. It also exists in the schizophrenia spectrum section, which is where schizotypal can be found in the ICD. The Psychodiagnostic Manual makes use of some different terms, so it calls antisocial personality disorder psychopathic personality syndrome. It calls histrionic personality disorder hysteric histrionic. It expands somewhat upon avoidant personality disorder, and contains 3 personality syndrome categories not currently represented in the DSM or ICD. So keeping in mind that the Psychodiagnostic Manual is for case formulation and therefore relies a lot on the expertise of the clinician, let's take a look at the organization of the personality axis. First, you're going to determine the level of personality organization of the individual, regardless of whether the problem appears to be a personological or characterological one or not. This is something that should be assessed. This is also described as severity of personality dysfunction. Also assessed is your style or type, and you can have a style without having a disorder. So let's zoom in on personality organization. On the left side here, we have the organized personality, the healthy or mature personality, and on the right side, we have the disorganized, immature, psychotic level of organization, typically characterized by use of primal defense mechanisms. Now, something interesting is that you could be organized at any level, even without any diagnosis. I might be able, for example, to stumble through my entire life in complete denial of nearly everything pertaining to reality. If I can stumble through in that state of personality organization, then I don't have a diagnosable syndrome. Importantly, nobody is perfect all of the time. So a healthy or organized personality that uses mature defense mechanisms might still experience psychic symptoms under stress, but in part it'll be their flexibility that will help them get through stressful times when their usual go-to coping mechanisms aren't quite enough. With a neurotic level of personality organization, the main issue seems to be that you are less flexible. So your one trick that you have, maybe it's regression, maybe it's reaction formation, you tend to use so exclusively that you use it in situations where it's not appropriate, Or maybe you use it so often that it becomes transparent to you that you are using it as a defense mechanism, so you don't even trust your own ego defenses. Quoting the PDM, what we see here is relatively restricted range of defenses and coping strategies. And what this means is, it might not be reality that's in your way, it might be your way of dealing with reality that is the problem. A good example would be obsessive-compulsive personality disorder. You probably have a pretty good handle on reality. In fact, it's probably overhandling reality that is the source of many troubles that you might have. Another characteristic of the neurotic level of personality organization is that the challenges the individual is facing tend to be quite specific. So with OCPD, it might be control or orderliness. Other examples of neurotic challenges might be trouble with rejection or authority, or maybe you're stuck in a self-critical loop. Individuals with neurotic levels of organization, because the problem is generally focused, tend to have good insight into what their challenges are, and since they perform well in other domains, they don't have much trouble imagining what improvement would look like were therapy successful. Their connection with reality also makes it easier to form good therapeutic alliances, because they can see them for what they are. And if someone with a neurotic level of personality organization does experience reality distortion, such as when someone with OCPD exaggerates risk, these distortions tend to be confined to their problem area. In fact, under the normal DSM-5 model, most individuals with neurotic level personality organization by PDM standards would not be diagnosable. Those with borderline personality organization are on the border between sticking with and breaking from reality. Whatever their preferred defense mechanism is, they tend to apply it pretty much everywhere. Maybe this is denial, maybe this is the defense mechanism of splitting, which is also called black and white thinking, needing a person, situation, or idea to be either all good or all bad. This tends to be where projection lives. It's a tricky defense mechanism when it comes to negative emotion, because sometimes you may be right, and sometimes you may make yourself right. If someone comes up to me and in a non-joking way says, "Why are you so shallow and mean?" my second response, my first would be to make a joke about it, but my second response would have to communicate that there's something wrong with the question, maybe that its insinuation is incorrect, which would probably be taken as negative emotion toward the person who asked. Another borderline level defense mechanism is called omnipotent control, which isn't quite as grand as it sounds, but the idea is that you're affixing a label to something makes that thing whatever you labeled it. You could imagine having a conversation with someone who is labeling or judging what you're saying. That's a rude thing to say. That's wrong. If you object and then the judger comes back with something along the lines of, "No, it felt rude, so it was rude," or "It felt wrong, so it was wrong," then you're dealing with the omnipotent control defense mechanism, preventing them from learning that they could be wrong or that there's nuance in the world. Here also is the defense mechanism of dissociation, which is generally a profound shift in how you are. So maybe to protect yourself from experiencing too much happiness, you shift to anger or despair, and maybe to protect yourself from despair, or the social judgment and consequences that come with it, you switch to ecstasy. An example from a case of borderline personality disorder, which tends to operate at the borderline level of personality functioning, even though one is a syndrome and one is a level of organization, was a husband who was describing what it's like to live with someone with borderline personality disorder, and he said that when he comes home from work, what he wants to do is just put his hat on a stick and then put his hand through the door holding the stick on the hat and then see how his wife greets the hat. Does she go for a kiss? Does she ignore it? Or does she attack it? The idea being that moment to moment, he just doesn't know what to expect. And he wants to come home, just not to the attack version of his wife. Lastly, I include introjective identification because it demonstrates a problem that an individual with a disorganized level of personality organization would have, which is, who am I? Or maybe even, what am I? Though the what am I problem would be called lack of object constancy. If you're using denial, you're dissociating, and reality around you is changing with your mood. You might have trouble hanging onto a core that could guide your decisions and make you predictable to other people. You might not even know what you like. So maybe you find a friend, or a role model, or a romantic partner, and you just copy and paste their beliefs and life goals onto yourself. You dress like them, talk like them, maybe even with more dedication, and you think that's you. But of course you might not have the background to pull it off, and this Control V you probably won't feel good for long. So it's another defense mechanism that has you straddling between barely functioning and at utter odds with reality. It's at the borderline level of organization that you tend to see the truly primitive or immature defenses as well, the most prototypical of the category being primitive idealization. You encounter a love interest or a religious leader, or maybe both, that you see as perfect and having all of the answers, and you want to subordinate your life to them because they make the chaos of you make sense. At least for now, that's primitive idealization. And the idea is that that's just copy and paste from you interacting with caregivers as a helpless child. As could be deduced or inferred from the defense mechanisms on the previous slide, the borderline level of organization is prone to extremes and to shifts between these extremes, often precipitated by the onset of negative emotions, which naturally tends to elicit negative emotions in others, although in part by virtue of the types of signals that these individuals are sending out, these primal and immature signals, they do tend to find people with Florence Nightingale or White Knight syndromes that think they can rescue them or help them. So with this personality disorganization, you're getting into things that would be disorder level concerns like relational challenges, stress precipitated self-harm, impulse related issues, and the therapeutic tack here is going to depend on where the individual tends to fall. If the person with borderline organization tends more toward higher functioning or neurotic states, then the typical approach is insight, the ordinary psychoanalytic approach. But where individuals don't have the skill that requires, or consistency that requires, the focus might be on getting these borderline individuals some more tools in the way of other defense mechanism options before you start work on building up or looking at the core psychic issue. Therapists tend to have rules regarding how many borderline cases they can do at one time, or at least how many that are leaning more towards psychotic level of organization. This is in part because it's difficult to maintain rules and consistency and boundaries with borderline individuals. Finally, the least organized level of personality organization, psychotic. Here, you are regularly distorting reality in order to protect yourself, your ego, from it. Quoting the PDM-2, people with the most severe personality disorders may impute their own thoughts and feelings to others, so projection, become convinced of the rightness of their most erroneous perceptions, omnipotent control, and act on the basis of these perceptions. So your acceptance or construction of reality seems to be phasing in and out, and with this comes also the primitive defense mechanism of annihilation anxiety. If you think you're gonna die or disappear, then pretty much any response or action is justified. Pretty much any need you have should be met. Nearly anything you say or demand should be granted. This is your life. Do others not care about it? Of course that questionable thing you just did is justified. Of course the dubious plans you have are righteous. Of course your small failures and missteps can be excused. Your existence is on the line. No one can judge your ego negatively, and the only correct action for anyone to take is to save you. Control V from infancy, annihilation, anxiety. An integrated example here for psychotic level of personality organization, you have poor reality testing, poor separation of fantasy from reality, and lack of differentiation between self and others. What does this look like? I stalk her because she really loves me. Now let's assume that he really loves her, so his thinking that she loves him is a lack of differentiation between himself and her. I stalk her because she really loves me. And it's obviously protecting his ego, because unrequited love would put him in a bad light. But this is an incorrect belief, so reality should be able to take care of this very simply, through her actions or statements indicating that she's not into him. But here it's the case that he thinks this despite the fact that she has said that she does not love him. So we have poor reality testing, reality can't do its normal corrective work, and the errors pile on top of each other. That's enough for now. Stay tuned.